first some positive side, some negative sides. Okay. Why this last 2 3 years, this has been a debatable for this liraglutide. Particularly, my concern regarding that in 11 and 12, lot of research has been regarding your chip cells of thyroid and liraglutide and thyroid. What are the data you have collected regarding this, and what is the status now?
The current status is that there is a warning in the label saying if you have a family history of thyroid cancer, then you should be avoiding it. But liraglutide per se does not cause any MTC, the medullary thyroid carcinoma. That has been shown in animal studies. We are in the process of evaluating those patients from these lead studies, trying to extrapolate the data and perhaps come up with an observational study in those patients who have, but there has been, so far the data that we have collected, there is no raise in calcitonin levels so far. And it is not a contraindication it's not a contraindication, there is a warning that if you have a family history, then it has to be used with caution. It's not a contraindication. Current status is that.
Contraindication, I think men too.
Men too.
Multiple endocrine neoplasia
Men too
too.
is a contraindication.
It is a contraindication for this.
Medullary cell carcinoma, before, same thing. That it was initially there was a hesitation whether to launch this molecule as to because of the medullary cell in animal study.
Yes,
not proven yet. And
not proven
that's
yet.
why
In fact, this is true of all GLP-1s. It's not only liraglutide. It is not yet proven in the market. No, not. It's not. There is no statistically significant, or rather any data which shows that there is an increase in the chances of having medullary thyroid carcinoma with a GLP-1 receptor agonist.
Pancreatitis, what the
Pancreatitis, again, one of the very debatable issues. Generally, a type 2 diabetic patient has a higher chance of having pancreatitis. Once again, over here, all the studies that we have done, and we have collated the data of adverse events, there has been no increase in pancreatitis events so far. Yes, because there has been some concerns, this has also been taken a step forward and is being evaluated in further studies. But currently there is no data linking any of the GLP-1 analogs to increased risk of pancreatitis. Type 2 diabetes patients generally are predisposed to pancreatitis. That by itself is a pathophysiological process of the disease. So whatever incidence of pancreatitis that was reported across any studies of GLP-1, it is not a causative indication with the GLP-1 molecule. Whether it was because of type 2 diabetes or whether it was because of the GLP-1 therapy, the causality has not been established. So for sure we cannot say that GLP-1 analogs cause pancreatitis. We cannot definitely say they don't cause, but we cannot say they do cause either. Similarly with DPP. Similarly with all the incretin-based therapies actually.
Whether you will change in case of renal failure patients?
In case of renal, the dose, in mild to moderate renal failure patients, those need not be altered. In severe, there are no studies. That is why we say go with caution. Again,
whether we should reduce from 1.2 to 0.6?
No, as of right now, for mild to moderate, there is no such there is no such cause for concern. In severe, again, there's been no such data. Again, like I said, these were all done in normal type 2 diabetic patients without any altered renal function. So that has come up with us as well, and there are a lot of projects in the pipeline with Novo Nordisk which is going to evaluate these things, and a lot of trials are underway. Similarly, liraglutide in obesity is also being evaluated. Phase 2 is already published, and phase 3 study is also underway in obesity in non-diabetic patients.
Can you use in the end-stage renal failure, second stage 5?
As of right now, there's no data to say it is safe, so I'd rather not use it.
What about your discussion with Dr. Mohan? Have you talked to these things?
Yes, he said he doesn't use it. That's why I said there's no data. So I would not use it. I would not even ask anybody to use it in end stage. Mild to moderate is fine. Not in severe or end stage.
About 30 ml per minute?
You shouldn't, because there is no data to prove its safety.
How does it decrease the blood? Although the data you have shown, the lead studies, the decrease in systolic blood pressure was not really very significant. It was to the tune of approximately 5 mm mercury, if I am correct.
Yeah.
So, if that be the case, what was the mechanism of action? I mean, how did they?
That mechanism, again, this is not an antihypertensive agent. This was a chance finding. we found in the lead studies. The exact mechanism we are going to evaluate, but it is postulated it is through the BNP, the natriuretic peptides. Again, the mechanism is being evaluated because this was a chance finding, and this was not designed to be an antihypertensive medication. So even a 6 millimeters of mercury is quite a big amount for something which is not designed to reduce blood sugar level, blood pressure levels.
Only for the triglyceride level, your
Yeah.
data is safe for the TG reduction. So one proven factor against this is the triglyceride as an anti-lipid strength.
Yeah,
And
again,
one important fact now, again, new research are going on, particularly like the once weekly your exenatide, Bydureon.
Bydureon, yes.
So Bydureon is now in market. They are saying ki once daily, twice daily, once a week, once a month.
That
So
is one
many
peg,
research
peg
is
one,
going
I think. Pegylated, peg one.
So Bydureon versus this Liraglutide. Is there any head-to-head strategy?
There is a head-to-head study, yes. That is being evaluated. Bydureon once weekly versus Liraglutide once daily is being evaluated as a non-inferiority trial. It's underway.
Because more and more things that
Definitely.
less space, less
Less injection, yeah, definitely. Yes, of course, it's going on. It's an ongoing trial. In fact, it's being done by Eli Lilly only.